Antianginal Drugs. This is Professor White. The first thing we want to do is define what angina is. Sometimes you'll hear it called angina. I've always stuck with angina. So angina pectoris is the actual name, that is chest pain. And to understand the mechanism of chest pain, we have to remember that the heart is actually a muscle. I bet you any one of us has done some exercise at some point where we felt the burn in our legs and the pain that results from over-exercising or even sometimes just exercising. But what we end up with is a mismatch in the supply and the demand of oxygen. And when that happens in the heart, we have a lack of oxygen. Remember, the heart being a muscle, that also builds up lactic acid, and that lactic acid causes the pain receptors that are located around the heart and near the heart, that they get stimulated, and as a result, the heart experiences pain, and that pain is called angina. If the heart is without oxygen long enough for any tissue, really, ischemia results. So some of the main causes of ischemia are listed here: coronary artery disease and atherosclerosis. If ischemia is allowed to continue, it disrupts the function of the heart and causes death of the cardiac tissue. That is called a myocardial infarction or a heart attack. Angina is generally classified as three different types. One is chronic stable angina. This is the classic one that we think about when we see the patient who's taking the nitroglycerin that's supplied to them by their provider. So this type of angina is generally triggered by exertion or stress and usually subsides within either 15 minutes of resting or of drug therapy. It is the result of atherosclerosis, most commonly. Unstable angina is sort of the point where your angina is no longer responding to the medication. We consider that to be unstable, or if it starts to happen at rest. This one is really a pre-infarction. It means that you're heading for a heart attack. And then the vasospastic or Prince metal, that's a special sort of angina. It happens when a person is relaxing or resting. Most cases of this occur between the hours of midnight and 8 a.m. It usually affects younger, healthier people rather than those with the traditional angina risk factors. And it's found in other people who have conditions related to their blood vessels like migraines and Raynaud's phenomenon. In that case, Prince metal or variant, many different names, but it's caused by spasming of the coronary vessels, and it can lead to some trouble for sure, but it's not very common. Only 2% of all angina cases are Prince metal, and the treatment is pretty much the same. The drugs used to treat angina are really aimed at correcting that imbalance of oxygen supply and demand to decrease the amount of ischemia and decrease the probability of having a myocardial infarction. There are three main classes of drugs that we use to treat angina, and these include the nitrates and nitrites, our beta blockers, and calcium channel blockers. These are very commonly given medications in the hospital setting, and patients are commonly prescribed these in the outpatient setting as well. So as we delve into some of our medications, the nitrates and nitrites, that'd be the first group of medications we go into. And these are known as the vasodilators. We'll get into that in just a little bit. But there are several different forms of these medications. Many of them, especially nitroglycerin, are available sublingual, IV, in translingual sprays, they're patches. And if that's the case, those bypass the liver in the first pass effect. Anything that is chewed and swallowed that will not bypass the first pass effect of the liver. So just be aware of that. That's why we use some of our IV medications when somebody is very acutely ill, and we'll tend to use oral preparations, things like that, when the patient is being treated for chronic angina more as a preventative. The mechanism of action on the nitrates is pretty interesting. So a little walk down anatomy and physiology reminds us that the heart has arteries that feed it, and also we need to have a good amount of oxygen-rich blood supply to the heart, and that also feeds into the coronary arteries as well. And our vasodilators actually, the nitrates, when they're taken into the body, they release nitrous oxide, which is a vasodilator to the smooth muscles. It causes relaxation there. And those smooth muscles are our veins and our arteries. So this causes the coronary arteries to dilate. This also causes dilation of the other vessels, which has some of our untoward effects as well. But one of the bigger effects is that it will decrease afterload, or the force the heart has to fight against to get the blood moving. And because of the vasodilation, it will also sort of fix the amount of oxygen available that's going into the heart. The big result of it is that we start to get some oxygen-rich blood into that ischemic tissue. So these nitrates and the nitrites, they are used for acute treatment of angina as well as the prevention of angina. So the indications for use of these medications, as we've sort of been talking about already, is the treatment of our stable anginas, treatment of our unstable anginas, and also of the Prince metal. So all three types of angina can be treated with this medication. Those rapid acting forms, that's what we're treating our really acute anginal attacks, whether or not they're leading to ischemia and actual myocardial infarction. And we'll see giving the sublingual at this time, IV forms of the medication to reduce that pain. And the long-acting forms we use to prevent, which makes sense. As far as contraindications and considerations, obviously a known drug allergy to the medication will be a contraindication. Now I want to back up here just a minute though and tell you that a lot of people who report that they're allergic to transdermal nitroglycerin aren't really allergic to it. What they are is allergic to the carrier system or the delivery system, but not the medication itself. So just bear that in mind. In severe anemia, it's contraindicated in patients with closed angle glaucoma. People with hypotension, this is a vasodilator. One of the side effects is decreased blood pressure. So if they're already hypotensive, we would run the risk of hypoperfusion. Folks with severe head injuries, and then also recent use of those erectile dysfunction drugs. So they end in a "-phil", so sildenafil, tadalafil, and vardenafil, which most common is going to be Viagra or sildenafil. This is why it's very important to ask your patient if they've had that medication in order to see if you can safely give them a nitrate. Otherwise, the patient will generally experience extreme hypotension. The adverse effects of nitrate administration can be quite profound and severe. Headaches is generally the first thing and one that patients really complain of. However, especially with continued use of it, it will decrease. I would remind you that anything that is absorbed by the patient can be absorbed by the nurse who's administering it. So as we're giving topical preparations of nitroglycerin, I've seen it happen where nurses have had it on their skin, and the only time I've had it inadvertently put on my skin, I also suffered a profound headache, and I've seen providers literally pass out. Reflex tachycardia. So this is a complex thing where the heart notices with its baroreceptors a decrease in the blood supply because of the vasodilation and starts to increase the heart rate to try and push more blood to the vital organs, and eventually the peripheral baroreceptors will catch up and shut that heart down a little bit more, but it's potential to happen. Hypotension being a big problem. This is why we have holding parameters on nitroglycerin. As an EMT, we used to make sure that the blood pressure was over 100 when we gave it systolic, and now we're actually up to 120 millimeters mercury systolic to safely give it outside of the hospital setting. I've been with patients where we'll give the medication and patient with, active heart attack, whether it's NSTEMI or not, but I've had my patient literally go gray and drop their pressures into the 60s and 50s systolic, which is just about as scary as that sounds. Again, the skin irritation, which many patients consider potentially to be an allergy, and tolerance, right? This is why we make sure that we remove these items at specified intervals. Let's check that out on the next slide. So tolerance is a pretty big issue that we need to be concerned about. So people who take it around the clock or taking those long-acting forms can develop tolerance. And how we get around this is by giving a nitrate-free period, right? This is specifically important when we have our patches and things that are placed on the skin daily. So we do recommend that they be removed for 8 hours at bedtime. I know this little thing says 12 hours, but that's just a clock, right? Telling you to remind yourself that these medications have to be removed at certain intervals so that the patient doesn't develop tolerance to them. Some of the other nitrates that we have in addition to nitro, remember both the rapid and long-acting, we have isosorbide dinitrate and isosorbide mononitrate. The most common one that we give is the isosorbide mononitrate, and that's because it's a little bit more stable in its therapeutic response. People are more likely to be compliant with it. Isosorbide dinitrate, as you can see here, needs to be taken at scheduled periods within a 12-hour period with a 12-hour free nitrate period as well. When you do this, the patient does have a really nice sort of therapeutic response as well, but not as good compliance. So kind of go back and forth on that. So again, IMDOR or isosorbide mononitrate would be the primary one that I've seen throughout my career. All right, so nitroglycerin, this is going to be the prototype drug that you will really want to be aware of. It is, as it says here, the most important drug that we use for the people who are having very symptomatic heart disease with signs of ischemia. As we spoke before on this, there's many different routes available to this medication, and it's important to know when we should be using them or not. There is a very, very large first pass effect with those oral forms, so anything that we're swallowing. So that's something to be aware of. We do use it for ischemic heart conditions, so chest pain. And we do have the IV form of this. So we use IV nitrates to control our blood pressure. We use it to treat heart failure, chest pain related to heart attacks and for hypertensive emergencies. So be a few different meds, but really the nitroglycerin group. Patient teaching is especially important regarding nitroglycerin. So some things that we should be talking to our patients about is making sure that they know the proper technique and the guidelines for actually taking their sublingual nitroglycerin, which is going to be the most common sort of rescue medication that we give to patients as an outpatient. So you'll see them carrying their nitro with them. And I would say that They should carry their nitro with them. If their medication is at home in the medicine cabinet, it will do them no good if they experience chest pain elsewhere. Your patient should make sure they store those nitro pills in the original airtight dark container that is given to them with the meds. It's how the meds come in. And that once they open that medication, they have about 3 months until the potency degrades and it may no longer work. The patient should take it at the first sign of chest pain. Okay, so at the first sign of chest pain, the patient, we want them to stop their activity, to either sit or lie down and take their medication. And if they get no relief past the first dose, then they should be calling 911 at that time. That whole thing that patients can take it 3 times over 5 minutes apart before they call is false. It's after the first dose if it's not working. If nitro is going to work for the patient, it generally will after the first dose. All right, so they should call 911 or their family should call 911. At no point should they be taking any more than 3 tablets, but they can take additional tablets while waiting for EMS to arrive. Want to make sure that the patient receives proper administration and application. So anytime we're putting on nitroglycerin patches or ointments, you need to make sure that, especially the patches, that we're putting them to a non-hairy area where they're going to stick. Make sure any old patches are removed first. They can wear their patch while doing activities, even water-based activities. However, if they come off, it should be replaced. A lot of people will be using the transdermal patches for long-term relief of angina. So if somebody was having a heart attack, that wouldn't be the time to put them on a patch, if you understand what I'm saying here. And make sure you have your time frame where it's off the patient's body, and make sure you teach them the same about that. Vital signs should definitely be checked before administration of this medication. They are potent vasodilators. They will cause a decrease in blood pressure, okay? It's not if they will cause it, they will cause it. And for IV use, understand that we need to have non-PVC infusion kits. Some places do stock that just as regular stock, and other places you may need to get it special from your pharmacy for it. And that's because the nitrate, if we use regular IV tubing, can be uptook by the tubing itself and will decompose the nitrate and not make it as potent as it should be. It is given by itself. It's never given as a piggyback. We never IV push it. And if you have any sort of solution that is not clear, please don't use it. All right, so that is some of the major nursing implications for nitro. We're going to be moving on to the next class of medications. So the next class we're going to talk about are our beta blockers. These are the meds that end in OLOL. I always call these the funny meds. Metoprolol would be our prototype. And we'll talk about these a little bit more as we go on with the slides, but I did like this one kind of as an overview of some of the side effects and what it's doing. So, and then you can see the other names there. We have Inderal, Tenormin, and Bistolic. Now those are all trade names. So see if you can figure out what the generic names are for those. These medications are a mainstay of treatment, and as such, you need to learn them. All right, I want you to take some time and go over all of these meds and make sure you have them mapped out pretty well and can figure out what we're using them for in our patients. And we definitely will use them quite frequently. You will come across these. So by group of medication, again, you can see they all in that OLOL or LOL. Atenolol, metoprolol, propranolol, and nadolol. So these are some of the drugs that you should just be familiar sitting in that class of beta blockers. So how do beta blockers work? Glad you asked. So here we have what they actually do. Our beta blockers, if they're cardioselective, they block just beta 1 mostly, but if they're non-cardioselective beta blockers, they'll work on beta 1 and beta 2. So beta receptors are in the heart, and when they are blocked, the result is a decreased heart rate and decreased contractility of the heart. This is pretty important for us because after a myocardial infarction, the body is in fight or flight, and one of the things that happens is that all those vessels clamp down, and post-MI, beta blockers are important for survival. So again, post-MI, a lot of times they don't recommend giving them right in the midst of a heart attack. It's often contraindicated, but after somebody survives a heart attack, these are good meds. So here are some of the main indications. So chest pain, hypertension, cardiac dysrhythmias, including those tachyarrhythmias like atrial fibrillation and SVT or supraventricular tachycardia. People take these for relief of premature ventricular contractions or PVCs. We give it after heart attacks for heart protection. And then some other different forms of these beta blockers, they're used for headache prevention, they're used for tremors, they're used for people who have nightmares and PTSD even, and also used for stage fright, because you have to look at the mechanism of action with the sympathetic fight or flight response in the body. And if you can envision these blocking that and causing that calming sensation, because the heart rate can't ramp up, the anxiety can't ramp up as a result of that feedback loop. You can see the positive effect of these meds on all of these things that I've talked about. All right, contraindications. So anybody that's in systolic heart failure, so there's a couple different types of heart failure, but systolic means they can't pump the blood forward. Well, if we reduce the contractility of the heart, that will worsen heart failure. People with serious dysrhythmias, these can cause increased dysrhythmias and heart blocks. Anybody with asthma, we need to be very careful with them because these meds can affect beta 2 and cause exacerbations of asthma. Diabetes, this can actually cause increase or decrease in the blood sugar. But here's the kicker. One of the problems is that if a person is having hypoglycemia, we rely on the sympathetic nervous system to tell the body that it's in trouble. And we look at those signs and symptoms, tachycardia, jitteriness, anxiety. When we have beta blockers in play, we may not get those signs and symptoms, so it can really mask those. So anybody with diabetes who's on these medications, we need to make sure that they are aware of the importance of frequent blood sugar monitoring. Right, peripheral vascular disease, that it can compromise cerebral or that blood flow to the brain, or peripheral as well. So the adverse effects, and honestly guys, sometimes these are the effects we want, but we don't want too much of the effect, if you understand what I'm saying here. So we may want a decrease in heart rate, but maybe we don't want the patient bradycardic. As you can see here, I have the patient with a heartbeat of 39 beats per minute. That is not too good, and their blood pressure is on the low side. So low blood pressure, low heart rate, we can put the patient in heart blocks where we're blocking the conduction from the sinoatrial side through the AV node. Again, changes in their glucose. Dizziness can cause wheezing because of the beta 2, and dyspnea, shortness of breath. Some of the other issues that can occur are impotence and lethargy. What else? Let me just check here for if I had anything else. Heart failure, if it's developing or worsening because of these, even though it's used to some of these are used to treat heart failure. So we'll want to make sure we're monitoring the patient's weight. So now we are going to move into some of the exemplar medications in this class. The exemplar med is metoprolol, also known as Lopressor or Toprol, Toprol XL. This is cardioselective, so it's going to block beta 1 more than the others. It is used for prophylaxis of angina, and again, all sorts of other reasons we might be using it for tachyarrhythmias, things of that nature. It works much like atenolol, so when we see these meds, you can say they're pretty much very much related. We talked about metoprolol decreasing mortality after a heart attack. We do have oral forms. We have metoprolol tartrate. So I remember tartrate being tart, like if you're putting something on your tongue, it's really brief and almost want to spit it out. You don't keep it in there. It's short acting. So that is tartrate. And we also have metoprolol succinate. And you think if you have a hard candy, you can suck on that for a long time. So that medication is the long-acting one. So tartrate has to be dosed several times a day, and succinate has to be dosed generally once a day. And then we have the injectable forms. We use the IV forms after heart attacks. We use them. I use them a lot of times when I have a person who's had a procedure where they remove part of the lung or go in for diagnosis called a VATS, or basically it's a thoracic surgery. Because of the chest tubes and the manipulation in there, the patient's more predisposed to things like atrial fibrillation, so we will give this medication preventatively. So let's look at some of the nursing care for this. Monitoring that pulse daily. Make sure your patient knows how to take their pulse and that they should be letting their provider know if their pulse is under 60 consistently. Changing positions slowly. As the beta blockers reduce the heart rate, they reduce the ability of the heart to increase its beating when the person stands, which leads to more orthostatic hypotension. We don't want patients to abruptly stop medications because it can cause rebound effects. And it's not used for short-term relief of pain, which is a very interesting thing, but they're not really just used for that. So I have on here a dizzy patient and the fall risk. So as nurses, we need to make sure that we're educating patients on their fall risk and taking steps to mitigate any falls. All right, so here's the last class that we'll talk about in this little lecture. We're talking about the calcium channel blockers here. Another cartoon I found that I find very helpful. So these are known as the very nice drugs. These are verapamil, nifedipine, and diltiazem. And what they do is decrease contractility and conductivity of the heart by blocking the action of calcium. So as we started to talk about that just on the previous slide, basically by blocking calcium, these calcium channel blockers allow blood vessels to relax and open. So that decreases the systemic vascular resistance, decreases cardiac workload, and that therefore decreases the amount of oxygen that the heart is demanding. And the other thing that it does by slowing conduction in the heart is it can slow down our fast rates of the heart and slow down conduction so that maybe we can get out of those arrhythmias. So we tend to use diltiazem or cardizem drips on patients that are in atrial fibrillation with a rapid ventricular response. So AFib with RVR, we call that. So here are the indications. Certainly you can read these, just give it a little pause. And one of the other drugs that are there, that nimodipine, that's a little bit special. It's for cerebral artery spasms if the person has an aneurysm rupture. So that has fairly limited use otherwise, but it belongs in this class. Some of the contraindications, once again, we have our allergies listed. People who are having an acute myocardial infarction shouldn't have this. Those who are in heart blocks, as long as they don't have a pacemaker, should not have these drugs. Remember that the medication slows down the conduction through the heart, and it does have an effect on the sinoatrial node. People who are hypotensive, this is a good contraindication for most of these meds. And look at the adverse effects, right? So hypotension, palpitations, that's the pain, it's not pain rather, but it's an unpleasant sensation in the patient's chest where it feels like their heart may be beating faster or skipping beats. Tachycardia or bradycardia, so the heart may raise or lower. Constipation is actually an interesting side effect here. Remember, as calcium's being blocked from going into certain areas, it's circulating a bit, slowing things down. So constipation, nausea, and shortness of breath. So let's take a look at a couple of the drugs in this class. We have diltiazem, which again, very, very common to be used for treatment of atrial fibrillation. It is really, really effective for those. It's got kind of a really good affinity for that. Also really decent for treating of hypertension. It's one of the few that are actually available in IV form. So we'll use that in various settings within the hospital. Now, amlodipine, very common outpatient medication. Norvasc, people take it quite often for chest pain, but more frequently for hypertension. It's only available orally, and it is a very common prescription. There is another med that doesn't belong in the calcium channel blockers, but it's called ranolazine. They don't even know how this thing works, but we're starting to get new meds, and you can read about it in the text a little bit, but it really just says it doesn't know how it works at all. But the effects that it has really don't involve decreasing the heart rate or the blood pressure, but it does prolong the QT interval, so that can be a problem. All right, so as we wrap up this lecture, we're just going to talk about some of the nursing care of antianginals in general, looking for contraindications in our patient's history and to medications to make sure that they are on the right medication. We want to make sure we're monitoring their blood pressure and the heart rate. Make sure you teach your patients that too. They should have home blood pressure monitors, and they should be able to take their own pulse. We want to limit caffeine intake. Be always aware of the risk for orthostatic hypotension and encourage our patients to change positions slowly. Encourage them to keep diaries, I must be getting tired. Diaries about their symptoms that they're having so that when they see their doctors for follow-up, they can discuss them. Patients should be taught to report any of the following conditions if they're having changes in their vision, headaches that won't go away, dry mouth, edema, if they faint or pass out, if they're gaining weight, right? All of those might be signs of heart failure. If their pulse rate is consistently less than 60, especially if they're symptomatic, if they have any shortness of breath. With our calcium channel blockers, one of the main problems that we find with that is actually constipation. So we want to provide good teaching for our patients that they should get enough fluids, high fiber foods to help things move along, monitor their vital signs. And another thing for calcium channel blockers is that they should not have grapefruit juice, because grapefruit juice decreases the metabolism of the calcium channel blockers. All right. Well, thanks for sticking with me throughout this lecture. Hopefully you've learned a lot and can now go back and look at our objectives for what we were doing with these medications, and hopefully know a little bit more about our nitrates, our beta blockers, and our calcium channel blockers. And because of that, you'll be a better nurse who knows how to monitor your patients and teach them the right things. Thanks again.